Good afternoon, everybody. Welcome. My name is Chris Woolforth. I'm the Acting Director of the Dickey Center for International Understanding. It's my very great pleasure to introduce you to our speaker and to this afternoon's presentation. As many of you may be aware, the Dickey Center for International Understanding at Dartmouth concerns itself with providing opportunities for Dartmouth students and the larger community to engage with the pressing international issues of our day. Today's presentation, Rebuilding Medical Systems in a Post-Conflict Nation, is one such opportunity. It is particularly relevant as it combines two of the fundamental challenges in society today: ensuring a healthy population while at the same time building a stable society. Our featured presenter is particularly well qualified to share with us the challenges he has and is facing for providing health services within the new and developing nation of Kosovo. Dr. Ferid Agani is a neuropsychiatrist. He received his MD from the University of Pristina in Kosovo and a master's and PhD in psychiatry from there as well. He has pursued extensive postgraduate and continuing education studies in the United States, the United Kingdom, France, Germany, Japan, Poland, Spain, just to name a few. He has published widely on the challenges of providing child, adolescent, and family mental health services in post-conflict environments, and in particular in Kosovo. He is a professor of psychiatry at the University of Pristina and an adjunct professor at Clemson University here in the United States. He is president of the Albanian Psychiatric League and chairman of the National Mental Health Council of Kosovo. In addition to his medical career, Dr. Ferid Agani has participated in the political construction of the new state of Kosovo. He has twice been elected to the Kosovo Parliament, in 2004 and again in 2010, and is president of Kosovo's Party of Justice. In February 2011, he was named the Minister of Health. This is indeed a distinguished pedigree for a minister, but what makes Dr. Agani so aptly suited for his role as Minister of Health for Kosovo has less to do with his credentials, impressive though they are, than with the particular needs of Kosovo society. For 10 years, until NATO intervention in 1999, Kosovo Albanians were subject to brutal suppression by Serbian forces, part of a complex series of power struggles during the dissolution of Yugoslavia. Dr. Ferid Agani was among a small handful of Kosovar psychiatrists who provided mental health services before, during, and after the 10-year Serbian suppression of Kosovar Albanians. Following the liberation of Kosovo in 1999, Dr. Agani was a major force in developing child and mental health services in post-war Kosovo. The reasons for doing so were twofold. The Kosovar population is very young. At the time when Dr. Agani first raised concern for the lack of mental health services for children and adolescents, more than 50% of the Kosovar population was under the age of 16. Moreover, conflict-induced mental trauma was widespread. According to one of the first post-conflict surveys of mental health done in 2000, 62% of the population had been close to death at least once in the previous decade. A full 49% of the population had been victims of torture or abuse. 42% had been separated from family, and a full 26% had experienced the murder of family or friend. 10% of the population had been imprisoned, 4% sexually abused. If you add up the numbers, the result is the traumatization of an entire population. And remember, more than half of this population are children under the age of 16. So it is uniquely logical that a psychiatrist should be tasked with the challenge of building a health system for a nation emerging from trauma. Setting aside the particular needs of Kosovo, it is also logical that one would task someone familiar with the challenges of establishing trust on an individual level with building a national health system. For perhaps more than any other public service, healthcare depends on trust. The trust between patient and physician, the trust between society and a sponsoring government in order to be effective. We are very grateful to have such a distinguished guest this afternoon, and equally pleased to have the Consul General of Kosovo here also to join us. So let us now hear about the specific challenges of building a healthcare system in a post-conflict nation, Please join me in warmly welcoming Dr. Ferid Agani.
Thank you, Chris. Thank you, Chris, for this great introduction. It's my honor and privilege to be here today with you and to say a few words about the rebuilding of the healthcare system, medical system in my country, in Kosovo. The privilege is motivated, first of all, because I'm in one such respected academic U.S. institution. United States is a country that has largely respected in Kosovo by Kosovars and in the region for its large contribution that is given to our nation in the process of liberation from a severe occupation and very hard repression that was exposed during more than a decade. The other base for feeling honored and privileged is the fact that I'm speaking in the Dartmouth University in front of Dartmouth students and officials, institution that is highly respected in the United States and all over the world. It is my pleasure to be able to say a few words about our efforts that we made in the period from 1999 and later in trying to recover our country. It was a very difficult period of time. And maybe you could get something from my presentation at the end of my talk, and maybe you could come with some conclusions about that, what is needed to try to face the complex circumstances of a post-war country. Very complex circumstances that I will try to say a few words in the future period of time. I have decided to speak to you today about the mental health reform in my country as one section of the rebuilding of the medical system in the country, for what I will say more tomorrow in presentation in front of the faculties at the Dartmouth Hitchcock Medical Center. I have chosen to speak about this particular part of the reform because it is much easier to understand. It is in the context of post-war country, and what is more important, the conclusions that were drawn from this process that lasted from 1999 to 2004 has a lot informed the later reform of the overall healthcare system in the country. So we learned in this process, and we use that. We use these facts. We use this knowledge in designing the overall health sector reform that we are planning to start just in few weeks in front of us with adoption of the new health law that has been passed in the first hearing in the Kosovo Parliament, and it will be voted somewhere at the third week of November when I'm back home. So there is a process, and there is a continual process of learning, continual learning in order to be able to find the best solutions. I started my engagement in the health sector of Kosovo as a student, undergraduate student in the School of Medicine in Pristina in 1978. So I was in your age, and I did my medical studies there. Then later on, I get engaged in my residency training in neuropsychiatry, neurology and psychiatry. So I was a clinician. Then I became assistant at the Faculty of Medicine in Pristina. Then the occupation started. Then I continued my clinical work as a clinician. Then after the war, as a reflection of my professional and national responsibility. I get engaged in the reform of the healthcare services. So from a clinical work, using experience that I got from the work in services, I get into policy making waters. First as a part-time official in the Ministry of Health. At that time I met Professor Strickler here. We had a short talk. I think it was 2001, Professor, 2001, or very early. And later on, I became a director of the Department of Strategic Management. Then further working in the ministry, being a member of parliament, getting into political waters, always motivated to work on the benefit of citizens. Always with a motivation to be in position from where I could more influence the process in order that people has benefit from my work. And in that process, then I finished as a Minister of Health, where I'm now here. So I'm in 1 year and a half, more than 1 year and a half in my mandate, and there is another 2 years, I think, until the end of the mandate, if we succeed to survive as a government. We'll see. Okay, so now I will start my presentation. So this is the Republic of Kosovo, a very small country in territory. It's about 11,000 square kilometers. It has 37 municipalities. The capital of Pristina is somewhere here. It has a population of 1.7 million people. Gender equality is almost there. Urban 40%, rural 60%, so more living in rural areas. Very young population. Under 26 year, there are more than 50% of the population. Then over 65, only 6.7%. A very characteristic fact was the fact that we have 1.1 million citizens living abroad. This is a demographic fact that we understood just 2 months ago. And this is reflecting that period of occupation, 1990-1999, where a large majority of the population was in very slowly pushed to get out of the country to other European countries and the United States. Economic situation is pretty difficult. We have about 35 to 40% unemployment, and poverty rate is pretty high, about 40%. And 20% of population is living in extreme poverty. These are facts that characterize the Republic of Kosovo at this moment. So this is how our country looks like. It's something like New Hampshire, but a little bit higher hills. Very different landscapes within a small territory. You could see different landscapes. There are valleys and there are high mountains and ski centers of 2,500 meters in a very small territory. Foreigners, when they come, they find it very beautiful as a country. We think also that it's nice. But this is a sad story of how our country looked in the summer of 1999. So this is what Professor Strickler, what Professor Friedman saw when they came to Kosovo in the early post-war days. There were 130,000 burned homes. Intentionally burned homes completely. And this is a reburial of bodies from mass grave near Macedonian border. So there are still 1,400, even these days, missing people in the country. So 1,400 families that don't know where their beloved are, practically. In the summer of 1999, one official of the World Health Organization said the people are severely traumatized and the mental health system is almost non-existent. There is little hope for the future of mental health. This was a statement made by Peter Elzas, Norwegian expert that was really felt very bad, and he was severely embarrassed with what he saw in the field of psychiatry and mental health status of population. We had very poor institutional resources, very little number of beds. All psychiatric healthcare, mental health care was hospital-based and was provided in the psychiatric wards only 152 beds. There was no single bed for chronically mentally ill, no child adolescent mental health services, and you saw that half the population was under 21. No forensic psychiatry services, no substance abuse services, and there was one social psychiatric asylum with 240 clients in Shtimia. And this was one photo from that asylum. This is a town nearby Pristina, it's the capital, some 20 kilometers. And you see this is a photo done in summer months of 1999. Human resources were also very poor. Only one child psychiatrist, 19 adult psychiatrists, one psychiatrist per 110,000 inhabitants. Only 2 clinical psychologists in the country, 57 nurses, and no social workers with psychiatric background. So very poor human resources, and the needs of populations were extremely high. A need for changes was enormous, and in multiple levels, in services levels, in the clients and their family level, and the community level. Everywhere we needed to change something in order to be able to respond to very high mental health needs. Some of the data Chris has mentioned. These are data from a survey research that was done in May 2000. It was a CDC team from Atlanta. I was a part of the research team, and this was published in JAMA in 2000. So you see figures here. 62% of population 15 years and older was close to death. 49% victims of torture. 42% separated from family. 26% has witnessed murder of a family member in front of them. So a brother or a child or father or mother. And 4% were sexually abused. Prevalence of post-traumatic stress disorder was 25%. Very high. Every fourth Kosovar older than 15 years had the signs and symptoms of post-traumatic stress disorder. And what happened immediately after the war, I have written there NGO Caravan. This is non-governmental organizations. Then they dropped from Bosnia and Herzegovina, where they had a lot of similar programs. They just came to Kosovo with millions of dollars and euros funded programs from different relief organizations. Of course, the countries and governments were trying to help our country, and they give a lot of money to these non-governmental organizations, but the majority of them had programs that were not structured for particular needs of population. They made copy-paste programs from one country to another, from Cambodia to Bosnia, from Bosnia to Kosovo, like we are having the same type of problems, and they were not the same. We have very different situation because, for example, Kosovar population experienced 9 year of occupation from 1990 to 1999 under severe chronic psychosocial stress that has exhausted the population. And at the end, we had the traumatic war experiences and the ethnic cleansing. 1 million Kosovars were pushed out of the borders in Macedonia and Albania and European countries and even the United States. So it was very different psychological, psychosocial situation related to Bosnia, for example, that don't have that occupation, but they had severe war, more than 2 year lasted war with a severe casualties. That was also difficult, but in other contexts, and it was a different situation. But they brought, just imported, copy-paste, trauma-oriented psychosocial programs trying to help. Research that was done has demonstrated that there was a help given, definitely, but also a lot of these resources were not used in a proper way, and they have not given the proper effect that it was supposed to have. Local professionals were bypassed, and generally it was low interest to develop public mental health services. So these were projects that has engaged experts, many times even recruiting from a public service and making more weaker the system. Then we needed to respond. So we are talking about July, August, September 1999. We needed to have a response as professionals. What are we going to do now? There are 400 NGOs were in Kosovo implementing psychosocial programs. And the burden upon the psychiatric services was very large. The most severe psychiatric patients, they were coming to public institutions. They were not going to NGOs because they were dealing only with debriefing and other types of techniques dealing with stress and trauma. then we decided. We had the Neuropsychiatric Association of Kosovo that was working even during the period of occupation. That organization gathered in 1999, September 1999, together with WHO, World Health Organization. And then we said, we need to develop, to formulate a policy. A policy, what are we going to do? How are we going to approach? Of course, WHO was bringing standards and principles. They say, we will develop, we need to rebuild this mental health system, and we need to put this mental health system on community basis. This is WHO principle, community-based mental health system. That concept was so far from our professors of psychiatry that were biologically oriented, that were learned to treat patients in the hospitals. The concept of community-based mental health services was completely unknown for them. So we needed to provide specific answers to the situation, trying also to manage the resistances within our own professional community. Then, of course, we did a literature review. We read a lot. Then we established a multidisciplinary and multisectorial task force from whatever we had. Initially, we included also our professors in the task force, but they very quickly refused to be a part of that because they had other opinions. They wanted to have very quickly a large psychiatric hospital. They got 500,000 Deutschmarks from UN administration because after the war, country was ruled by UN administration, United Nations administration. There were no local, there was no Ministry of Health, there were no local government institutions. It was UN administration. And they wanted to build quickly a psychiatric hospital in order to respond to the needs of population. Of course, we resisted. Older colleagues, they wanted to have a psychiatric hospital as soon. So it was a very large tensions within the professional communities. But we worked as a task force. We produced a policy document. No, we decided to have a policy document, a strategic plan for mental health. So we decided to work on it. Then to establish, based on the strategy, the legal framework on which we will organize the new system. And of course, we'll try to establish monitoring mechanism and, if possible, to do some research related to that. This research remained a wish for a long period of time because it was impossible. It was very difficult to perform research in these circumstances. And then the task force start work on 21st of November, 1999. So 21st of November was some 5 months after the war has ended. And we start to work. After 1 year of work, we had a strategic plan for mental health. And we adopted the plan in February 2001. So it has taken 1 year to develop a plan, to write it. And a large contribution in the writing of the plan gave also the team from University of Illinois at Chicago, a team of experts. They were collaborating with us. And the basic principles of this document were two. First, we are going to establish community-based, family-centered, integrative model of medical and psychosocial services. So you see, community-based, yes, this was WHO. Whatever you see later, this is our Kosovo input. Family-centered, integrative model, not only psychosocial, but medical and psychosocial, because there is a need to respond also to common psychiatric problems, not only to trauma-related mental health disorders. And of course, we don't want psychiatric asylums. We said we don't want psychiatric hospitals. So this was not easy to achieve, and it has gone through a very serious discussions with our older colleagues. But at the end, they agreed with us, and we were together. But it has taken 1 year of negotiations with them until we succeeded to come to a kind of peace between. It was not a general support, but at least they don't make serious problems. So at the end, they were large supporters of the overall process after a few years. So this plan, this strategic plan, was articulated interest of local professionals and international professional community. So it was a joint venture. I did something wrong. Okay. Why family-centered? You saw that it's community-based and family-centered. because this is cultural characteristic of our community. The Kosovar population has a very strong family structure, still strong family units that take care about the mentally ill, that take care about the ill members of the family, in particular for parents. That is something that is not changing this 13, 40 years, despite severe cultural transition through what our society is going, and despite very strong tendencies toward individuality and nuclear family organization, like in many other countries, as a part of the process of modernization and globalization. But the family structure is still very strong. It continues to exist, and this is a good sign. So they are very strong social units, and of course, evidence-based practice. Evidence-based practice show that the family basement of the mental health service on the family is always more productive. Implementation of the plan was a very difficult part. Of course, we need to change behavior, attitude of the professionals. I say a few words about that. Policymakers and society. The greater resistance was coming from UN administrator in the health sector. He wanted to have a psychiatric hospital quickly to resolve issue with 500,000 Deutschmark, build institution, put psychiatric patients in, and the problem is resolved. But of course, we don't allow that. Then we developed both human and institutional psychiatric capacities. All this process was largely supported by international community. We had a strong network of international organizations that supported this overall process. And among them, you see World Health Organization, American Family Therapy Academy, University of Illinois in Chicago, etc., several of them. Legal framework and financing was presented with a strategic plan for mental health, 2 regulations, and the general health law in 2004 has legalized all the process. And we established completely new structures. This was not existing before the war. We built it. 9 regional mental health centers, 8 homes for integration, each of them with 10 beds. This was alternative for psychiatric hospital. University Child and Adolescent Mental Health Center, University Drug Addiction Unit, 2 inpatient psychiatric wards, new one, and 4 intensive care psychiatric units. We did this, we built this, and this was a large contribution for building the institutional capacities. It was really very interesting to see when we built the first home for integration, that is a house in 2 floors for 10 people who lives in the middle of community. And we took patients, you saw that center asylum, the photo that you saw in the beginning, people from there, we took and put them in the house. And they were living there, and there were no problems at all since then. No single problem in each of these 8 homes for integration. So it was really a great change in perception of the mental illness. Then we developed human resources. We succeeded to establish the Department of Psychology in the faculty, in the University of Pristina, and there has finished with a bachelor's degree about 400 psychologists. We started these days, especially training in clinical psychology. 58 psychiatrists has finished the residency program, 2 child adolescent psychiatrists, 154 nurses, etc. So the resources start to be built. Organizationally, we have organized these mental health centers and these homes for integration into 7 integrated, regionally based mental health services. They were completely sufficient for the needs of the population in their catchment area. So they don't need to be sent to another institution to get needed services. So they were fulfilling the needs, and they are continuing to do that. Each of these centers and these services has the mental health boards. They coordinate activities between family medicine services, mental health centers, and inpatient psychiatric wards. Of course, there are a lot of problems in functioning of these mental health boards. It was not so easy. It is in the paper, it's easy to put, but when they start to work, then you see it's very difficult to change attitudes and to establish a teamwork, coordinated work. And it's still continuing to have problems, but we are working in that direction. It's the only way to go forward. Each service had 1 mental health center that is outpatient, for outpatient mental health care. There is inpatient psychiatric ward with intensive care psychiatric unit in the regional hospital, home for integration, I said, and the child and adolescent mental health service. So each of 7 mental health services has these units. And what they do, the mental health centers, what they do, they provide individual consultations in the centers, home visits to patients within their families, as outreach team, mobile teams with vehicles. They go to the homes of family of the patients, and they, with the most difficult patients, of course, they cannot go to each of them, but they have identified the most critical one, and they follow them on weekly basis and bi-weekly basis. In the centers, we start to develop multi-family group psychoeducation programs. So we produce the manual with 8 sessions, with which we teach families how to deal with their patients. So what is schizophrenia, for example? What are symptoms? What are the signs of exacerbation? What drugs need to be used? Why is the importance of regular taking drugs? What are side effects of drugs? What to do in a certain moments, etc., etc. So this was education of the families. And initially, we don't have a large presence of families in the groups. And then we understand it was economic reason. Then we broke decision to pay €5. This is like $7 per family for each coming. So they will come in 2 members. And then the presence in the meetings was much better. So this was a way to bring them there. So we needed to find solutions for problems on daily basis. Okay. And then we had a new reality in the field. Field has started to change. So you saw more institutional resources, more human capacities in the mental health field. The multidisciplinary outreach mobile teams were regularly visiting clients. Asylum in Stimle, that Stimle is a small town near Pristina that I saw. You saw a photo from there. 240 clients. It dropped to 51 now. So where these people went, this other part, we have all integrated them back into community. We sent some 80 of them. We sent to homes for integration. And then the additional part, we start to reintegrate slowly to their families, wherever they had families. Some of them we sent to the social institutions that were built up in the same model. And by time, these institutions now has other face. This remaining number are mainly Serbian patients that were brought to Kosovo during the period of occupation. And unfortunately, they were brought from other parts of former Yugoslavia. They don't have families. We don't have where to reintegrate them. So for the moment, we are taking care about them in this institution, but it is a much better shape now than it was before. And the number of hospitalizations in the psychiatric ward declined for 40%. And if we go now in psychiatric wards in Kosovo, you will see that they are almost half empty, because the number of hospitalization has dropped, because the care for patients was much better in the families, and especially the number of rehospitalization. Some words about sustainability of the system. It was necessary that all this reform process was associated with organization in the administrative level. In order that these reform ideas to become realized, I needed to move from a department of psychiatry to a part-time position in the Ministry of Health as a mental health officer. So I was a part-time mental health officer in the Ministry of Health. So this ministry that I'm now chairing. This was 2001. Then, in order to implement it even more, then I needed to move, not part-time, but to be full-time official, and I was become a director of the Department of Strategic Management. This was a time when the ministry was built, and the ministry needed people, needed qualified officials, and then it was my duty now to move from the psychiatric position to that position. But I have to say that I have never stopped working with patients. Never stopped. Even now, as a minister, once a week, twice a week, I go and work 4 or 5 hours with patients. This is keeping me alive. Otherwise, I will be exhausted with this political work. Absolutely. But as a that result, as moving to the Ministry of Health, it was possible to establish separate budget line for mental health services, and we established mental health office in the Ministry of Health, and we established National Mental Health Council that was taking care about the policies in mental health sector. So this was a process. This is the interesting process of the leadership. When you move from a professional leadership as a psychiatrist toward a political leadership. Administrative first, as a civil servant, and later on as a political leadership, in order that you make ideas be realized. In a post-war country, this is a way how things happen. Otherwise, what would happen if I will remain as a psychiatrist in the Department of Psychiatry, if I will not have courage to move to a political institution, to a governmental institution, then many of these reform ideas will stay somewhere in the table of one of the officials in the Ministry of Health and will never be realized. Will never be realized. So this was a process of the work. What were the obstacles? Of course, obstacles are very large. Families live under very severe economic conditions. The financing of the health sector in general is very low. Overall, health sector is funded with 130 million euro. That means about, let me say, 70 euros per capita. That is extremely low, very low. We still lack institutional resources. We didn't succeed to establish the second chain of mental health centers and the homes for integration, because there was a lack of financial means. Even now, as a Minister of Health, I'm not able to divide money for that. Why? Because there are many competing priorities at the same time. And the areas of these 7 mental health centers are very large. So they cover about 300,000 inhabitants. Also, maybe not 300,000. If we look now, this large census, these are figures, old figures. So 1.7 million, we could say that maybe they are somewhere about 250,000 inhabitants in all. But there's still large catchment areas, and we need to double the number of mental health centers and homes for integration. 40% unemployment, 40% in poverty. People live with less than $2 per day, and 12% with less than $1 per day. These are people under social assistance. These are large obstacles for mental health reform, but also for health sector reform. That I will say a few words at the end. What are opportunities that the mental health reform had? We were able to build a new system. We don't had need to transform existing structures. This was opportunity. This was a great opportunity for us, and we used it maximally. We built a new system, and the resistances for that, although they were existing, were not so large. How they will be, if there will be, for example, before one large psychiatric hospital, etc. Because in the former Yugoslavia, Kosovo had 2 psychiatric hospitals that were very near. One was built in Macedonia, that is 80 kilometers from Pristina, and other one was in Niš in Serbia, some 100 kilometers, and both of them had 1,200 beds. So these 2 hospitals were in 2 other republics, so we don't have them in the country. We were lucky with that. Otherwise, we will have a very, very large problem. So this was opportunity, and we use it. The financing was low, but it was stable because there was separate budget line. This was very important. Our international partners were very committed, and there was increased interest of the community. And of course, the large opportunity now and in future is the ongoing health sector reform. The health sector reform that will start now will give a chance to these mental health services to boost their activities, because they will become a part of a more dynamic, more flexible healthcare system that will provide higher financial opportunities. And since we have ideas and the plan is there, so we just need to implement. So this will be a large opportunity. And all this had direct reflections in the life of patients, of course. The patients were much more satisfied with the level of care. And I will show you just one photo from that social institution. You see this lady here. This was the August 1999 in that social asylum nearby the capital. And you could see in the next photo when she met after 15 years with her son and daughter that were living only 20 kilometers from there. They didn't see her mother because she was crazy in this asylum. Nobody wanted to go there because they were afraid to go in that institution. You see these faces? And after we built the home for integration in Pristina, we transferred her to a new facility, and then the outreach teams understood where her family was living, and then we found them, and this is a meeting when they were together. You see that you could see this woman now, and with the son and the daughter. So this was a concrete result of the mental health reform in Kosovo after the war. So this is what I wanted to say in my presentation, and I'm happy to answer to your questions. Chris.
Mr. Agani, that was
Yes,
great.
no, please.
The Minister has very kindly agreed to take your questions. We do have a microphone or two that will be circulating, so please wait till the microphone gets to you if you have a question so that we can pick it up on the videotape that we're making today. So, as is the Dickey Center tradition, we will take questions from students first. If anyone has a question for the Minister, please raise your hand and we'll get a microphone to you. This gentleman down in front, please. Wait for the microphone.
Hi, sir. My name is Syed Arshid. I'm 14, which means I'm a junior here at Dartmouth College. I was just wondering, you said mentioning the budget allocation or financing for the mental health programs was low but stable, and you said there were other competing priorities, which was why you guys weren't getting as much financing. I was wondering what those competing priorities were in the budget.
Yes, thank you. We are talking about 1999-2004 period of time. Even 8 years later, so it's 2012, we still don't have cardiosurgery, possibilities for cardiosurgery interventions in the country. We have just started these days to offer oncology services, chemotherapy and radiotherapy for patients. Still some advanced tertiary healthcare services like more advanced neurosurgery and orthopedic services are not available. So these are these competing priorities that don't allow that we think to build a new set of mental health centers and homes for integration. If we will have another set of 7 mental health centers and another set of 7 homes for integration, we'll fulfill the needs of population. So this is a case. So post-war setting imposes a lot of priorities, competing priorities that it's not easy to fulfill because the healthcare is very costly and financial means in a post-war country are very low. Our budget of the country in 1999-2000 was 500 million euro. 12 years later, we have succeeded to triple it, to make it 1.5 billion euro. So it's getting better, but very slowly. And then I'm talking about only priorities within the health sector. Otherwise, there are many competing priorities in the overall economy, like roads, energy sector, etc. Yes.
Hi there, my name is Emily. I'm a second-year medical student here at the Geisel School of Medicine. Having been lucky enough to go to Kosovo this past summer through the exchange program that Geisel has with Kosovo, I was curious to see what kind of continued roles do you maybe see Dartmouth specifically playing in this health reform process, particularly where might you see roles and need for Dartmouth when it comes to mental health reform?
Yes. Thank you very much for this question. You saw that I have not mentioned too much Dartmouth in my presentation because this was related to mental health field. And related to mental health field, Dartmouth was present through activities of Professor Matt Friedman, as a well-known expert in post-traumatic stress disorder. Even we had one paper, joint paper with him. So we collaborated in early post-war days in that sense. But the Dartmouth University was present in Kosovo since early post-war days with different projects. And of course, one of the most important one is this project of exchange of students and faculties that has helped to build bridges between two institutions. And I think this was an extraordinary experience. I think both for students from Dartmouth and for students from Kosovo. Some of the students from Kosovo, they are now coming back. And we have Dr. Akram, who has come, and he is now with Dartmouth Hitchcock Medical School and doing research in the field of epilepsy and cognitive impairments. So practically this is building up. Then there were specific projects about establishment of the health microsystems in the primary health care, and we did that in Jakova and Gilan. And these projects has left very clear sign, and very positive experiences are continuing to live with this within these institutions. Now, of course, there is a very natural move that I did as a Minister of Health when we designed the overall health sector reform. Now, you saw the mental health reform, so I feel encouraged since we had a positive result with the mental health reform. Why we shouldn't have a positive result with the health sector reform? So we will do it. And when I got a mandate, I worked in the same way like we did with mental health, but now in the overall health sector scale. There was a strategic plan for mental health. Here were two reform laws, health law and health insurance law. There was a strong collaboration you saw with which institutions, WHO, etc. Now we are collaborating very strongly with World Bank, with IMF, with WHO and other institutions. So again, it's a parallel process. Again, there is a need for change of attitudes, behavior, there is a need for better financing. So the reform processes has approximately the same characteristics. And the leadership, again, is very important. The leadership in all process is very crucial, almost. But all this process, without a strong backup of the evidence-based consultations and support, will not be successful. We had that during the mental health reform process. But now this is a very serious project, large project, that requires a very strong professional expertise and evidence-based practices. And I myself as a Minister of Health, was very normal that I will look at the resources available, what we have. And we have the Dartmouth University that was with us since early post-war days. They were there even in the time when we don't have the courage to invite them to come to help us. They were there without asking. Okay? So they were where we were in the largest need. So they show that they were there because of their humanity that lay down in the basement of their professional, scientific engagement. So I addressed this issue. We talked with Professor Strickler. We talked with Professor David Goodman, Laurel. We talked with the fellows from Dartmouth, with Ilir Hoja, his wife Iliriana, who is now a master student here in Dartmouth, and with others who were engaged, Professor Karahoda, that was a part of the exchange faculties in the Dartmouth. And we said that the Dartmouth University is really, very clearly, a large resource for the health sector reform in Kosovo. And I came here, I have been invited by President Folt to come and to analyze possibilities. What are the modalities where we could collaborate? And the health sector reform, I think, that is offering a lot of opportunities for engagement of the Dartmouth resources in the process. First of all, in providing research evidence-based practices, services measurements, the measurement of the success of the health system reform. So this type of expertise is very present, is highly present in the Dartmouth University, and we are in a large need for that. So this is a field where we could collaborate. Then there is a service delivery, particularly in the field of oncology and in the field of the primary health care. So practically to build up further systems of care. So I think that the Dartmouth University represent a large asset for the health sector reform in Kosovo. I hope that we will be able to design a new plan of collaboration and through a specific memorandum of cooperation define modalities of this engagement, where of course the exchange programs will continue to be a kind of cornerstones of this collaboration, but also start to engage in other fields, like I said, the overall health system reform, different aspects, and one particular project that is very near to my heart, and that is the reform of the medical school in Pristina, under the authority of the Geisel Medical School. If we could succeed to have that relationship and support of the Geisel Medical School in the reform of medical school of Pristina, I think that this would be the best possible start of the health sector reform in the country, because there could not be successful health sector reform without changing the attitude and the level of professional capacities of the healthcare professionals, and the medical school is the one that is producing them.
Hi, my name is Zana Thache, and I'm a senior here at Dartmouth. And I was just wondering if you could possibly elaborate on what your personal, I guess, goals or maybe steps that you wish to take in the immediate future. You said you only have like 2.5 years, right? Or something, sorry.
Yes.
But what your immediate goals are for the overall health reform and what immediate steps you wish to take.
Yes, thank you. Yes, of course, the mandate of the minister could be very short. You never know how long it will last, because the governments are like that. I was in a visit, just to tell you one example, and it was a teaching experience for me. I was in a visit to the Minister of Health of Slovenia, Dr. Dorian Marušić, and next day the government fall in Slovenia. You could imagine. So while I was there, he was not anymore a minister, and now he is my advisor in the Ministry of Health. So I took him through a support project of Luxembourg government, and we are working together. So I'm very lucky. So I said this just to illustrate that time is very valuable in the political life. So there is not too much time to lose. And what are the first steps? Of course, adoption of the law. I'm having a political battle. Initially, when I started the health sector reform, I stated that this will be reform that will be implemented through 2 reform laws. So the reorganization, restructuring of the health sector through health law, and immediately after that, or with that, in parallel, establishment of the public health insurance fund. This was much easier to sell to the parliament and to be promoted. Then I had critics from the World Bank and the IMF stating that there are not enough technical capacities within the Ministry of Health to implement both laws, because this is a very substantial reform. Then they said, let us make 2-stage reform. First health law, and then the second stage, health insurance law. Of course, this makes my life more difficult in the parliament, in the public, this and that. You are not able to establish health insurance fund, etc. So the level of public perception is very low. They don't understand that the health law is much more important than the health insurance law. Health insurance law brings money, but the health law provides a system that is much more accountable and more responsible for money that you have. If we don't have that accountable, responsible healthcare system, then we will lose all this money that will come through health insurance system, and it's just throwing money in the air. So first goal, objective, adoption of the law, of the health law. Then immediately establishment of the 3 new institutions foreseen with this law, and that is the Health Financing Agency in the ministry as the predecessor of Health Insurance Fund, establishment of the University Clinical and Hospital Service of Kosovo as integrated institution of the tertiary and secondary healthcare. So I will integrate all hospitals in the country into one institution. And we will organize them not based on the hospital management, but based on the discipline management. So we'll give budgets to chairmen of the professional services. For example, chairman of pediatric services, national pediatric services, that will have inside it pediatric services, child psychiatry, and child surgery, for example. So they will be grouped disciplines that are related to patient, because this will be a reform that will be centered on patient need, and the money will go after a patient, wherever he is. So this is the second institution. The third institution are medical chambers. All 3 institutions are new institutions. They are not existing at this moment. So this is a large challenge, and we are working since now in their establishment. Law on medical chambers has passed in the parliament in the first hearing. The Health Financing Agency, we are working with the World Bank, and the University Hospital and Clinical Service, we are working with Swedish healthcare institutions in trying to make the best possible management of this institution. So these are the main short-term goals. And of course, within the next 9 months until June of next year, we need to establish the price list and the basic healthcare package, the list of basic healthcare services, and this has been done already. So I think that when I'm back home, I'm going just to sign and to make them official. So this will make possible for us that somewhere in June of next year, we adopt the health insurance law. And then it will start the second phase of the reform. And fortunately, the general elections will happen somewhere in summer 2014. So by that time, I think there is enough time to do the basic work. So you see, there is not too much time for research. There is not too much time to consult the evidences. And here is the role of the Dartmouth, that in parallel with all this everyday, daily-based activities, we need a consultation side that will monitor what are we doing, are we on the right track, what are data saying about the services, because we need to make our adaptations in the course. So it will be a very interesting process, complex but interesting process. Okay, thank you.
Hello, my name is Rich Simons, and I serve as a Senior Associate Dean for Medical Education here at the medical school. So you spoke about the importance of the family unit in your country.
Yes.
And the last picture you showed of the woman with her family seemed to illustrate that point. Can you talk more about the family unit in your country and how that has contributed to your gains so far?
Yeah, thank you. Families are a very strong unit in the country, and the reason for that is the history of the nation. That in the last century, in particular, we were under continual oppression of a different type. Our society after the war is characterized, like Ambassador said today in one of the meetings, with 2 types of large transitions, and the first one was the transition that happened from a communistic economy toward a market-based economy. And in other side, we have a very severe cultural transition also from a period of time when there was a very, very, very large oppression and isolation of the society toward now a more open society, open to liberal ideology, etc. So the social and cultural transition of the country is very, very, very heavy, and the migration element is very strong in all this process. We have a lot of separated families during decades. Like I said, 1.1 million of people have been declared that they have family members out of the country. But in all this process, families were the unit through which individuals have succeeded to keep their inner stability, and the economic status of individuals was much easier to be protected within the family unit. And these were large families where several brothers lived. So there were 3 generations in one family, for example. And we could see that in rural areas still a lot of families with 3 generations in the family. So there's the grandfather, grandmother, then the mother and father, then the children are there. And even nephews in many of them. And they continue to exist like that. So I think it's the economic factor is the first one. The second one was the state oppression that make families feel more secure when they are together. So they don't, they are not isolated and not left aside, because practically there were no state authorities to take care about families. They were taking care about themselves. So these were elements that supported the fact that the families are very strong, continue to be a very strong element, and the remittances that are sent in the country are mostly sent on the family basis. So a large majority of families in Kosovo lived by the contributions that their family members sent from abroad in the country. When we discussed the mental health reform, then of course we built up our services based on that fact, because families were around the mentally ill person, and so we tried to build up to reinforce the family structure in taking care about the mentally ill. This was the most economic approach. When we design now the health sector reform, we again are going to but we are very, very strongly thinking about that, how we will continue with using of this family approach toward designing a new health system. When we come to the health insurance system to be established, we will base the contribution based on the family unit. So practically, the family will be a unit of the payment of contribution. It will not be individual. So in this way, we will again try to keep a balance, and for families that has larger number, to reduce the premiums of payments, and the families that has lower numbers, to increase the premiums so that will be paid, in order that we keep the kind of stability, and we don't create a large economic burden for families. So I think that the preservation of the family structure in the society has helped a lot our system to overcome existing difficulties. And we are facing a lot of difficulties, telling you the truth, in different fields. But it is much easier, for example, when you see old man with a heart failure, with a lot of health difficulties, but surrounded with 2 sons and a daughter that are around and taking care about him, and taking here and taking there, and trying to do the best. If they cannot within a public, they go in a private sector. If not there, then they go abroad. So it's much easier to deal with this type of problems than when you see individual alone. I had some families, some patients, and it's very difficult to see a husband and a wife in her 70s, barely cannot walk, and they are alone, and all their sons and daughters are abroad, and they cannot go out because they don't have visas. And Kosovo is the only country in Europe that don't have visa liberalization process still. So this is a pity and pretty unacceptable policy that European Union is having toward Kosovo, although we got a roadmap for visa, and we hope that during next year we are going to have that also allowed, and this will make things much easier for Kosovo citizens. The visa liberalization process will make a much easier life for Kosovars.
I think I have time for one more question.
I wanted to ask about my name is Andrew Garrett, I'm Professor Emeritus of Education. I wanted to ask about the relationship between the successes in your mental health efforts and the achievements of the justice system. if I think about Bosnia, your next door, Bosnia-Herzegovina, your next door neighbor, a country which I'm quite familiar with, and I've worked a lot in Mostar, students and adults will point out on the street murderers, people who have murdered their relatives, murdered their friends. And I went to Srebrenica, where the young Muslim man who lost his twin brother and his father told me that every day in Srebrenica he sees people who have murdered his people. So what can the accomplishments of therapy or counseling do when you walk out of the session and you're confronted with the injustice in the world? How has Kosovo managed with its criminals? And is it the relative homogeneity in Kosovo of Kosovo Albanians, does that help immunize them from people who would haunt them otherwise with the terrible things they've done in the past?
Yes, thank you for this question. I think that the answer that you gave in the last part of your statement is the right one. So what we had in Kosovo is that the pretty large part of the Kosovo territory remained homogeneous ethnically. I stated in my presentation what differs Kosovo from Bosnia is a 10-year period of occupation. And during this 10-year period of occupation, the Serbian community, in large majority, unfortunately, they don't let too much space for themselves for living in a close relationship with the Kosovo, with Albanian community. Because it was the apartheid, it was complete apartheid during 10 years. And hundreds of thousands of Albanians fled from the country, and the families were separated. A lot of young people, boys, they fled from the country in a fear that they will be recruited in the Yugoslav army, etc., etc. So what happened after the war was that the large part of the Serbian community, they just fled from several regions in the country, and so this left homogeneous territories where Albanians live in the large majority. So this has prevented a lot of this that you are talking about in Bosnia. Nevertheless, there are parts in the country where Serbian community lives, where we don't have these days, in the last, at least in particular last 5-6 years, we don't have any single problem on an ethnic basis. And we don't have this kind of situation because the criminals that were perpetrators of the criminal acts, the majority of them, they left country. They went to Serbia, the majority of them. There are cases, even these days, where they will be identified. Actually, these days was a court process against one of them, who was catched just 2-3 months ago by a witness that has identified. But these cases was much rarer in Kosovo than in Bosnia. You know, it's we have this situation that we are not faced so much with this kind of problems, although they are existing. Dealing with the past and that this transitional justice, this concept of the transitional justice and dealing with the war consequences is an issue that is trying to be addressed by government officials. We are working very closely with international partners in this direction. There is a general feeling in Albanian population that there is a policy that we could forgive, but we will not forget. That is in the nation. That tolerance toward the past is inherited in our nations. Also, there was large prevalence of feelings of revenge and retaliation in Albanian population. And I'm talking about the study that was done in 1999, CDC study. There were 2 studies done by CDC. I was a part of the research team. 1999, September 1999, and May 2000. The prevalence was very high. We're talking about 65 to 70%. If we compare the prevalence of feelings and thoughts of revenge, retaliation with what really happened in the field, we see a clear discrepancy. So the acting upon these feelings and thoughts was not in correlation with the prevalence of the resistance. So this was talking about that Again, our national structure is not very much revenge oriented, and again the family structure that I talked something about was helping a lot to consolidate these individual feelings and to bring them in the normal level. And the fact that, like I said, the majority of criminals has fled Kosovo. They went out of the country. So this is helping somehow to keep a balance. And the actual political developments where our prime minister just a few days ago had a second meeting with the Serbian prime minister in Brussels with mediation of the European Commission and also United States, is showing the fact that the Kosovo authorities and the Albanian nation and the general Albanian community is ready for normalization of the relationships. Of course, without leaving a right to ask for justice in every single case where the criminal act could be documented.
Wonderful. Well, thank you very much. Please join me in thanking you.
Thank you. Thank you, George. Thank you very much. Thank you.